Welcome to Chronic Pain. Is it all in their head? We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, formerly known as the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners in Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Daniel Claw. Daniel Claw is a professor of anesthesiology, medicine, and psychiatry at the University of Michigan, where he also attended undergrad and medical school. He completed an internal medicine residency and rheumatology fellowship at Georgetown University, where he held roles including chief of rheumatology and vice chair of medicine. He and his research team moved to the University of Michigan in 2002, where Dr. Claw helped grow the clinical and translational research infrastructure, becoming the first assistant and then associate dean for clinical research, and the first PI of the University of Michigan Clinical and Translational Sciences Award. This group has identified the critical phenotypic features of individuals whose nervous systems is amplifying or magnifying their pain, and as such has been critical in helping elucidate the importance of the central nervous system in all chronic pain conditions. And now I'll hand it over to Dr. Claw.
Hello, everyone. So the talk today will focus on a new way of thinking about diagnosing and treating chronic pain, and that is that we should be trying to identify what the underlying mechanism of an individual's pain is and treating the individual based on that underlying mechanism. And in particular, one of the things that we've realized in the pain field in the last 10 to 20 years is that a lot of chronic pain is coming more so from the brain than it is the region of the body where the person's experiencing pain. So over the course of the lecture today, I'll talk about how you can tell the difference between pain that is coming from the peripheral areas of the body where the person's feeling the pain, and pain that is coming from the brain or coming from nerve damage or nerve impingement. And then what drug and non-drug treatments are most likely to work based on which underlying mechanism or mechanisms is leading to an individual's pain. This disclosure slide reminds me to say that although I do a lot of consulting in the pharmaceutical industry to try to identify new analgesics, one of the big problems we have in the field of chronic pain is that the majority of the drugs we use to treat chronic pain in the year 2017 are derivatives of very old drugs, and we simply don't have extremely effective drugs to treat chronic pain. I'll talk a lot about opioids and a lot of the problems associated with opioids. Many individuals, myself included, don't think opioids should ever be used to treat chronic pain, but we'll talk about some specific types of chronic pain that are inherently even less responsive to opioids than all chronic pain. But other classes of drugs, non-steroidal anti-inflammatory drugs, cannabinoids, are really old classes of drugs, and one of the problems we have in the pain field is that we don't have the blockbuster, incredibly effective drugs to treat pain that we do to treat autoimmune diseases or hypertension or hypercholesterolemia, and that ends up causing problems. So I always start my talks with this slide that shows two different individuals' knee x-rays, and I pose the question, which person is experiencing pain? The answer you're supposed to give is the one on the right. The individual on the right has fairly severe osteoarthritis of the knee. They've entirely lost the cartilage in one side of the knee joint. They have bone rubbing against bone, whereas the radiograph on the left is an entirely normal knee radiograph. And if you're not a pain researcher, you might assume that most people or all people that have a knee x-ray like the one on the right would hurt, and that most people that have a knee x-ray like the one on the left would have no pain whatsoever. But that's simply not the case. And although I'm using osteoarthritis today as the, if you will, peripheral pain condition as an example, there's not any chronic pain condition where something that we can measure on an x-ray, an MRI, and laparoscopy, a cystoscopy can accurately predict who's going to be experiencing pain or how severe the pain is going to be. There always is a tremendous disparity between what you see on a radiograph or an MRI and whether someone's experiencing pain or not. And historically, we've thought that when we see these individuals that have pain, even though their x-ray or their MRI is normal, that there's some psychological or psychiatric factor contributing to their pain. But again, that's simply not the case. So when we look at osteoarthritis of the knee, when I was first trained as a rheumatologist 30 or so years ago, we thought of it as being our classic peripheral pain condition. But then study after study after study showed that there was a terrible relationship between what you see on an x-ray or an MRI and whether people are experiencing pain. 30 to 40% of people with that x-ray on the right, bone rubbing against bone in their knee, don't have any pain. And 10% of people with an entirely normal knee x-ray will have severe pain in their knee. So again, I'm using osteoarthritis as an example here of the fact that there's a tremendous disparity between what you see on a radiograph and whether someone's experiencing pain. But any chronic pain condition has this same feature. And again, when we see individuals that have a lot of pain that we can't explain based on peripheral or quote unquote organic findings, we have a tendency to blame psychological factors like anxiety, depression, catastrophizing. But it turns out that psychological factors explain very little of the variance between what you see, for example, on a knee x-ray and whether someone's experiencing pain or how severe that pain is going to be. And one of the interesting things that's occurred in the field of osteoarthritis is that as our concept of the disease osteoarthritis has changed, along the lines of what I'll talk about over the course of this lecture, we now realize that a lot of the treatments that we thought worked extremely well in people with osteoarthritis don't work very well. It turns out that non-steroidals, acetaminophen, or opioids have very small effect sizes in osteoarthritis of the knee. And in fact, the effect size or the average effectiveness of a non-steroidal or an opioid in osteoarthritis of the knee is about the same as the effect size of a drug like pregabalin or duloxetine in a condition like fibromyalgia or neuropathic pain. So the problem isn't just that we're not very good or we don't have very effective treatments for treating conditions like fibromyalgia. We actually don't have any very effective drugs for treating any type of pain, and those would include classes of drugs like non-steroidals and opioids that we used to think were more effective than they really are if you look at the latest Cochrane reviews or meta-analyses. And if we didn't know for sure that this model of osteoarthritis was flawed, i.e. that all the pain could be seen on an x-ray, 20 to 30% of people that have their joint replaced don't have improvements of pain. And I'll talk a little bit more about this and how this more recent revelation that the brain or the central nervous system is contributing to a lot of pain helps explain why there's individuals that have severe osteoarthritis of the knee that are not going to be made better by replacing their knee. So the condition that I'm going to use as a metaphor today to talk about the role of the brain in chronic pain is fibromyalgia. And when fibromyalgia was first formally developed diagnostic criteria in 1990, the diagnostic criteria were that the person had to have chronic widespread pain in all four quadrants of the body and had to have a certain number of tender points. Tender points are these regions of the body that you see highlighted in red on this individual, where if you apply about 4 kilograms of pressure and someone says they hurt, that's considered to be a positive tender point. So the original ACR criteria for fibromyalgia, which I strongly recommend against you using, because I'll show you the new criteria, focused on the widespreadness of pain and tenderness as the defining features of fibromyalgia. But then we realized that a lot of things about those criteria were actually wrong about fibromyalgia. And a more contemporary view of fibromyalgia is indicated on the right side of this screen. First of all, the entire person is tender. It doesn't really matter where you push in someone with fibromyalgia, they're tender throughout their entire body. And that was one of the many features of fibromyalgia that led our group and others 20 or 30 years ago to think that this must be more of a central nervous system problem than it is a problem with damage or inflammation in a few areas of the body, because you find that fibromyalgia patients are much more tender to heat, cold, different types of stimuli throughout their entire body, not just confined to those areas of the body we used to consider as tender points. And in fact, in the broader pain field, now fibromyalgia is really thought to be sort of the poster child for a pain condition that is being caused by the brain rather than being caused by damage or inflammation in the regions of the body where people are experiencing pain. And I'll talk about fibromyalgia as such and show you that some of the new criteria for fibromyalgia can be used as a measure of how much someone's pain is being caused by their brain, and thus help guide when you may want or need to use drug and non-drug treatments that are working more so in the brain rather than non-steroidals, injections, surgical procedures, which are only going to work if the pain is occurring because of damage or inflammation in the periphery. And so this slide shows you that there are now acknowledged to be 3 underlying mechanisms that can cause chronic pain. Nociceptive pain means that there's damage or inflammation in the area of the body where the person's experiencing pain. Neuropathic pain means that the nerves that are coming from the periphery towards the spinal cord are either damaged or pinched. But this third category of pain is the category that we didn't even know existed 2 to 3 decades ago. And in fact, now we realize that this is the most common cause of chronic pain in younger individuals, because if you look down at the bottom, conditions like fibromyalgia, functional GI disorders like irritable bowel, temporomandibular disorder, tension headache, interstitial cystitis, and other conditions like vulvodynia are conditions that are all very highly prevalent, especially in individuals under age 50 or so. And these are conditions that are really now all thought to be much more so brain problems or centralized pain states than they are a nociceptive condition or a neuropathic condition where the pain is either due to inflammation or damage or some kind of a nerve impingement. But if you look under that first category of nociceptive pain, just taking a careful history can help you identify whether someone's pain is coming from ongoing nociceptive input in the periphery, coming from a peripheral nerve, or coming from the brain. And so I'm just going to go over that briefly, and then I'll expand upon that as I go through the talk. If someone's pain in their knee is coming from their knee, and you ask them to localize their pain by pointing with one finger where their pain is coming from, they'll be able to do that fairly well if they have nociceptive pain. They might point to the medial or lateral side of the knee joint, and they might draw with a little circle where their knee hurts, but their pain will be able to be well localized. And the other thing about nociceptive pain is nociceptive pain typically gets worse when people are using that area of the body more often. Now, there's a caveat here in that nociceptive pain that is due to ongoing inflammation, as might occur in an autoimmune disease like rheumatoid arthritis or lupus or ankylosing spondylitis, those individuals might have stiffness in the morning when they wake up or stiffness after they haven't moved for a prolonged period of time. But even then, if they have morning stiffness, there would be a consistent effect of activity on their pain. Their pain would either be made worse or made better by activity. If you now go over to the second category, I think most clinicians know how to identify nerve pain. It typically follows the distribution of peripheral nerves. Most neuropathic pain follows either a dermatomal pattern or a stocking glove distribution. And then the other thing about nerve pain is that people will have discrete episodes of nerve pain, and they'll have other neural symptoms like numbness, tingling, or a lancinating quality of their pain that they can use to describe their pain. If we now move over to this third category of centralized pain, this really is quite different when you take a history. The first thing that will help you identify that someone's pain is centralized is they'll have pain in multiple areas of their body, not just one or two areas of their body. And the more regions of the body that the person has pain in, the more likely it is that their brain or their central nervous system is contributing to their pain. The other thing that we look for when we're looking for centralized pain is that centralized pain is very commonly accompanied by other central nervous system symptoms like fatigue, sleep problems, memory problems, or mood problems. And so when you have someone come in to see you that's complaining, for example, of low back pain, but when you do a more nuanced history, they don't really just hurt in their low back, they hurt in multiple areas of the body. They have fatigue and sleep problems in addition to that. And then another thing that's really important is to take a history in individuals about whether they have had pain in previous regions of the body. Individuals with centralized pain states will typically begin developing chronic pain in different regions of their body in their childhood or their teens. But the most common history we see in someone who at age 35 or 40 might develop fibromyalgia is that that individual started having pain in their childhood or their teens. They had growing pains, painful menstrual periods, headaches, functional abdominal pain in their teens. And the pain just merely moved to different regions of the body over the course of their lifetime before their pain finally became so widespread that someone used the term fibromyalgia. But their fibromyalgia didn't start at age 35 or 40. You can almost always see that fibromyalgia starts many years earlier than when it's formally diagnosed and presents usually with a number of different episodes of regional pain in different regions of the body before the individual has chronic widespread pain. One of the analogies I use to try to explain pain processing to patients, but for that matter, healthcare providers are helped by this analogy as well, is that the amount of pain that someone is experiencing is like the loudness of an electric guitar. And there's two ways you can get an electric guitar to be louder. You can strum the strings harder, or you can turn up the amplifier. And then in this analogy, the strings on the electric guitar are akin to the sensory nerves that we have going to bones and muscles and joints. And those different sensory nerves bring qualitatively different information from the periphery to the spinal cord and then up to the brain to tell you whether you're hot or cold. They bring all sorts of different sensory information. And so you can get an individual to have more pain, if you will, by strumming the strings harder. But the primary determinant of how loud an electric guitar is what the amplifier is set at. And the amplifier for pain is the central nervous system, i.e. the spinal cord of the brain. And these individuals with centralized pain conditions really seem to have much more of an amplifier problem than they have a problem in the region of the body where the person's experiencing pain. And that also, though, this amplifier analogy helps us explain why individuals, for example, with a knee x-ray like the one on the right, are not experiencing pain, why the 30 or 40% of people with that knee x-ray wouldn't be experiencing pain, is that now studies have been done and have shown that these individuals that have radiographic evidence of osteoarthritis but don't experience any pain are individuals that have a low amplifier setting. These are individuals that are inherently pain insensitive, whereas individuals on the other side of the continuum with a condition like fibromyalgia can have an entirely normal knee x-ray and have pain because their amplifier is set too high. This slide just shows in a more classic graphical manner that there really is a bell-shaped curve of pain sensitivity in the population. If you're not a pain researcher, you don't know how different those people at the left side of the bell-shaped curve are from people at the right side of the bell-shaped curve. but the more tender that an individual is throughout their entire body, that's a marker of where they are on this continuum. And individuals who are more tender will have more pain over the course of their lifetime, not because they have more damage of their knee or more damage in different areas of their body, but this volume control setting is really a strong predictor over the course of someone's lifetime of how much chronic pain they're going to experience, because it really, literally is telling you what that amplifier is set at. And so whether you like the term fibromyalgia or not, I don't really care whether you use the term fibromyalgia or use a term like centralized pain, because there's a lot of people who will always think fibromyalgia is the F word. But having said that, fibromyalgia really does help us explain or understand pain. And this term that Fred Wolf coined, Fibromyalgia-ness, is really an apt term, because one of the things that we got really wrong about fibromyalgia is that we shouldn't think of fibromyalgia either being present or absent in an individual. We should really be thinking more so of the degree of fibromyalgia that someone has. Where are they on that bell-shaped curve of pain sensitivity? And a lot of people who don't in any way meet criteria for fibromyalgia might still have high degrees of fibromyalgia-ness that would cause them to have more pain for the same amount of joint space narrowing or the same amount of inflammation in the periphery as in someone who might be at the other end of the fibromyalgia-ness continuum, who has very low amounts of fibromyalgia and thus doesn't feel pain unless and until there's really something wrong. There's severe damage or inflammation in the periphery that might finally lead that individual to start experiencing pain. So this slide shows the new criteria for fibromyalgia that replaced the criteria that were developed in 1990 and required that you do a tender point count. There's a number of different forms of these criteria. This happens to be the form that we use. On the left side of this form, you see that there's a body map that's looking at how many different sites of pain that people have. There's 19 different boxes in this body map. And when you give this form to someone, you ask them to check which of these body regions they have pain in, and that side of the form can be scored from 0 to 19 based on how many sites of pain the person has. When you move over to the right side of the form, you see that it asks people about fatigue, memory problems, and sleep problems, and it scores those somatic symptoms on a score from 0 if they don't have that symptom to 3 if those symptoms are severe. So if someone had moderate fatigue, you would score that a 2. If someone had slight trouble thinking or remembering, that you would score that a 1. And then those 3 questions that are labeled number 3, pain or cramps in the lower abdomen, which are essentially irritable bowel, the 1 point for depression and 1 point for headache. You see that is scored 3 points there, a total of 9 points above on the 0 to 3 scales for fatigue, memory problems, and sleep disturbances, and then 19 points from the body map on the left. And so someone's fibromyalgia score can go from 0 to 31 based on how many of these symptoms they endorse. And a score of 13 or higher is said to be that someone meets criteria for fibromyalgia. But I want to show you some data that suggests that we really shouldn't just look at people at the end of this continuum that meet criteria for fibromyalgia. I would strongly recommend you give this fibromyalgia measure to anyone that comes in with chronic pain, because it'll help you determine what extent of the person's pain is coming from the brain. The higher their score, the more of their pain is coming from the brain. The lower the score, the more of the pain is coming from the periphery. And this might then be very helpful for you to identify the right drug and non-drug therapies based on the underlying mechanism of the person's pain, rather than thinking that all pain is primarily due to ongoing nociceptive input in the periphery. Let me just give you an example of what I'm talking about here. Imagine you're an orthopedic surgeon and someone comes into you with severe knee pain, and they have an x-ray like the one on the right. They have bone rubbing against bone. Would you offer them knee replacement surgery? Sure, it would seem like a very reasonable thing to do. But what if that knee was in this person? This is a classic fibromyalgia patient, and I'm purposefully showing you the 2 ends of the continuum, where you could see that if we replace the knee in this individual with fibromyalgia, it probably wouldn't be nearly as helpful as if we replace the knee in someone who is only hurting in their knee. If you don't give out the entirety of the fibromyalgia measure, I really recommend that you at least use a body map, because a body map can be incredibly helpful. You can see neuropathic pain on a body map because you can see that they're drawing the pain in a dermatomal distribution or in a stocking glove distribution. And then you can also just look at how many different areas of pain that people have and get a sense of where people are in this continuum of pain. If people feel the need to cross out words and put new words, then maybe they'll need to be referred to psychologists. But I only say that partly in jest, but you can really learn a lot by a body map by just looking at the way people complete a body map. But I really want you to sort of reconceptualize fibromyalgia as being the tip of the iceberg. And there's a lot of individuals that don't meet criteria for fibromyalgia who really have the same fundamental problem. They have centralized pain, and they might have osteoarthritis or rheumatoid arthritis or low back pain or lupus or sickle cell disease. And in these individuals, the higher their fibromyalgia score, the less likely their pain is going to respond to surgery and nonsteroidals and opioids, and the more likely their pain is going to respond to drug and non-drug therapies that are working in the central nervous system. So I'm just going to briefly show you some studies that we've done here over the last couple of years at the University of Michigan that show how impactful this fibromyalgia measure is. The data I'm going to show you are people with osteoarthritis that got their knee replaced. So these studies that I'm going to show here were all led by Chad Brummett, who's an anesthesiologist here at Michigan. What we were hypothesizing in these studies is that if we looked at individuals, for example, that had severe osteoarthritis and they were getting their knee or their hip replaced, that this fibromyalgia measure, we hypothesized, would be predictive of how much opioids someone needed to control their acute pain. It turns out that the kind of pain that people with fibromyalgia experience is inherently unresponsive to opioids, and I'll talk a little bit more about that later, about why that is. But our hypotheses were that the higher the fibromyalgia score, the less opioid responsive the pain would be, and the less likely that someone would get better if we replaced their knee. So we were looking both at post-operative opioid consumption, as well as the pain relief someone derived from knee or hip replacement surgery at 6 months in these studies that I'm going to present. In these studies, we looked at anxiety, depression, catastrophizing, nerve pain, really anything that had ever been shown to predict either a good or a bad response to knee replacement surgery or hip replacement surgery. The only thing that was novel in these studies was that we had everyone also fill out this fibromyalgia measure before they got their knee or hip replacement surgery. And again, it can be scored from 0 to 31, 19 of the points coming from how many checks people have on the body map, and 12 of the points coming from how severe their fatigue, their memory problems, and their sleep disturbances are. So in these studies of individuals getting their knee or their hip replaced, each 1 point increase in the fibromyalgia score from 0 to 31 led to 9 milligrams more of oral morphine equivalents being needed to control these individuals' pain in the first 24 hours of their inpatient hospitalization. It made them 25% less likely to get better if we replaced their knee. And these phenomena were linear, starting at a fibromyalgia score of 0 and going up to a fibromyalgia score of 18 or so. And so it wasn't just people with a fibromyalgia score of 13 or greater, 13 being the cut point for diagnosing someone as having fibromyalgia, that were less opioid responsive and less surgery responsive. This fibromyalgia measure was highly predictive of surgery and opioid responsiveness, well below the threshold that we would use to diagnose someone with fibromyalgia. And a point of emphasis is that this phenomena was stronger than and largely independent of classic psychological factors such as anxiety, depression, and catastrophizing. This graph is a histogram. On the x-axis are the people in these studies' fibromyalgia score. You see the score from 0 to 31 on the x-axis. And then on the y-axis are the number of people with each of those scores. And you can see that there were 84 people with a fibromyalgia score of 0, 1, or 2. About 100 people with a score of 3 or 4, and you see for the distribution of those fibromyalgia scores. That red line, to the right side of the red line, people would be said to have fibromyalgia as a standalone diagnosis, but people on the left side of that red line wouldn't have any condition whatsoever other than osteoarthritis. But I want to show you how impactful, looking at two different individuals, patient A and patient B, both of whom are on the left side of that red line, what their opioid requirements would be in the immediate post-operative period, and whether they would be likely to respond to that knee or hip replacement surgery with at least a 50% improvement in their pain. So if we compare patient B, who had a fibromyalgia score of 12, because he had pain in his knee, but he also had pain in his shoulder and pain in one other area of the body, and had a little bit of fatigue and a little bit of sleep problems, and that got him up to a fibromyalgia score of 12. Whereas the patient A, only had a fibromyalgia score of 2 because he had pain in his knee and he had a little bit of sleep problem, a mild sleep problem. Patient B would need 90 milligrams more oral morphine equivalents to control his pain during the first 24 hours of their inpatient hospitalization, and would be 5 times less likely to have a 50% improvement in their knee pain if they had their knee replaced. These are not subtle findings, but neither patient B nor patient A is on the right side of the red line, i.e. neither of these has fibromyalgia, just that patient B has a much higher score on the fibromyalgia measure, indicating that they are less surgery responsive and less opioid responsive. And we have, in fact, replicated all of these findings that I'm presenting to you today in an entirely different cohort of women that were undergoing a hysterectomy for chronic pelvic pain, but the same amount of opioid non-responsiveness and surgery non-responsiveness was predicted by a higher fibromyalgia score, but again, well below the threshold that would be needed to diagnose fibromyalgia. And although it's easy to think of fibromyalgia as having a lot of psychiatric and psychological comorbidities, because many of these individuals do have prominent psychological and behavioral factors playing a role in their pain. These individuals who don't meet criteria for fibromyalgia don't have anxiety or depression or catastrophizing to any significant extent, and this fibromyalgia measure is still highly predictive of surgery non-responsiveness and opioid non-responsiveness. This fibromyalgia measure doesn't just tell you what isn't going to work, it tells you what is going to work. The drug duloxetine, which also goes by Cymbalta, works a lot better if someone's pain is coming from their brain than it is coming from their back or their knee. So this is a recent study that showed that the drug duloxetine worked better in low back pain patients that also had pain in multiple other body sites besides their back, compared to people with low back pain that had pain in just a single region in the back. So if you look to the bottom of that slide, that if someone had one site of pain besides low back pain, they were 7% more likely to respond to duloxetine. But if that person had 5 or more sites of pain besides having low back pain, they were 60% more likely to respond to duloxetine than someone that had low back pain in just their low back alone. So again, this measure tells you that drugs like duloxetine, tricyclics, gabapentinoids are more likely to work because these are the drugs that are working more so in the brain than working out in the periphery. Another set of studies here that was done by Yvonne Lee at the Brigham in rheumatoid arthritis patients shows that the drugs that we use to treat fibromyalgia, there's a serotonin norepinephrine reuptake inhibitor, milnacipran, which is an SNRI, that milnacipran really only worked in the rheumatoid arthritis patients in whom their inflammation was well controlled, but what was left behind after their inflammation was well controlled was fibromyalgia. About 20 to 30% of patients with an autoimmune disease like rheumatoid arthritis or lupus also meet criteria for fibromyalgia, and even higher numbers of the rheumatoids or the lupus patients will have some degree of fibromyalgia-ness, even if they don't meet criteria for fibromyalgia. And again, the higher that score, the less likely that person is going to get better just by treating the underlying autoimmunity, and the more likely you are going to need to use drug and non-drug therapies that are working more so in the brain. So if we go back to our three underlying mechanisms of pain here, a point of emphasis is that if you look at those diseases on the bottom, those are classic examples where osteoarthritis is the classic nociceptive pain condition. Diabetic painful neuropathy is one of the classic neuropathic pain conditions, and fibromyalgia is one of the classic centralized pain conditions. But all of these are really mixed pain states. Some people with osteoarthritis or an autoimmune disease or cancer pain have nerve pain or have centralized pain. Again, at least 30% of patients with autoimmune disorders, in addition to having ongoing nociceptive pain from their inflammation, also have fibromyalgia or centralized pain. But the converse is true as well. Some people with fibromyalgia or tension headache or interstitial cystitis, although those conditions are typically more so centralized pain conditions than they are nociceptive pain conditions, a lot of people with fibromyalgia have myofascial pain or osteoarthritis in addition to the fibromyalgia, so they have ongoing nociceptive input, and that needs to be treated because the ongoing nociceptive input can actually drive the central sensitization or the centralization of pain. So what you really have to do is start to try to move towards treating people based on the underlying mechanism of their pain, based on doing a better history, as I was talking about earlier, and looking at the quality and the character of the pain, and then decide what the underlying mechanisms of pain are in that individual. But you can't assume that because someone has the disease osteoarthritis or the disease rheumatoid arthritis, that is only nociceptive pain, that is only neuropathic pain in people with diabetic painful neuropathy, or that it's only centralized pain in people with conditions like fibromyalgia or irritable bowel. And this just tries to show on a continuum where these different conditions are. Acute pain is more nociceptive, which is why opioids work so well to treat acute pain. But as you move over into some of the chronic pain states, osteoarthritis and rheumatoid arthritis are more peripheral than central on average, but in some individuals, there's prominent central nervous system contributions to their pain. Sickle cell disease, Ehlers-Danlos syndrome, and low back pain are really more 50-50 brain problems versus peripheral problems. And certainly low back pain has a high rate of neuropathic pain, so you really have to look for that pain mechanism as well. And then individuals at the far right side of the screen with conditions like fibromyalgia, irritable bowel, temporomandibular joint disorder really have much more, on average, of a centralized problem. But it doesn't mean those individuals with those pain conditions can't have a peripheral problem as well. And so we've learned a lot about these centralized pain states, what's really causing them, what's really driving them. One of the biggest boons to neuroscience research has been the advent of functional MRI and other types of functional imaging. I'm going to just briefly go through what you see in these individuals with conditions like fibromyalgia when you do these techniques such as functional brain imaging. This next slide is the first fMRI study done in individuals with fibromyalgia. It was done by our group and led by Rick Gracely in 2002. And all the study showed was that the pain in fibromyalgia is real. When fibromyalgia patients were giving a low stimulus to their thumbnail, they said that it hurt quite a bit, even though we were only giving them about 2 kilograms of pressure to their thumbnail. On the top left side of that slide, you can see that when we gave the fibromyalgia patients in the red triangle a 2 kilogram stimulus, they rated it as a 12 out of 20 on a 0 to 20 pain intensity scale, whereas the controls, given that same 2 kilograms, only rated that as a 2. We could get the controls to hurt as much as the fibromyalgia patients, but if you see that red circle in the top right part of that graph, we had to give the controls 4.5 kilograms of pressure to their thumbnail to get the same amount of pain as a fibromyalgia patient got with 2 kilograms of pressure. And then when we did put the controls and the fibromyalgia patients in the fMRI scanner, we could see that the fibromyalgia patients were in fact having pain even at that low 2 kilogram stimulus, but the controls weren't having pain. We couldn't see pain in the brain of the controls until we moved the pressure up to 4.5 kilograms rather than 2 kilograms. So this was the first study that showed objective evidence of this increased volume control setting in people with fibromyalgia, but there have been a number of studies now that have shown these same findings on functional MRI, not just in fibromyalgia, but in subsets of people with low back pain, sickle cell disease, all these other conditions that I was alluding to. This study looks at the degree to which different brain regions are either too connected to each other or not connected enough to each other. This is looking at sort of the way different brain regions are communicating with each other. And there have been a number of different studies now showing that in people with conditions like fibromyalgia that have brain pain, the areas of the brain that increase pain sensitivity are too connected to each other, and the areas of the brain that decrease pain, like the areas that lead to the descending pathways that go from the brain down to the spinal cord that normally inhibit the upward transmission of the pain, those pain pathways, there's not enough connectivity to these descending analgesic pathways. Even the size and the shape of the brain changes in people that have had chronic pain for long periods of time. Most of the brain regions shrink in people with chronic pain, but a recent study published out of the network the NIH has studying interstitial cystitis suggests that the primary somatosensory cortex, which is the brain region that helps localize where the pain is, the secondary somatosensory cortex and the insula tell you what the intensity of the pain is, but S1 gets bigger in people the more widespread their pain is, the more centralized their pain is, and this is one of the biomarkers for a centralized pain states. But this is not just an academic exercise to really look at people that have centralized their pain. If you look at the drugs that work for centralized pain, first start at the bottom. The things that don't work are the things that work well for nociceptive pain. Opioids, corticosteroids, non-steroidal anti-inflammatory drugs don't work at all that treat conditions like fibromyalgia, and instead the classes of drugs that work the best are the tricyclic drugs, the serotonin norepinephrine reuptake inhibitors, and the gabapentinoids. Other drugs that can be somewhat helpful, tramadol is a very weak opioid, but it also is a serotonin norepinephrine reuptake inhibitor, and most of us think that's how it's working in most chronic pain conditions. The newer serotonin reuptake inhibitors that are highly selective serotonin reuptake inhibitors are not good drugs to treat pain, but the older SSRIs like paroxetine, fluoxetine, sertraline at high dosages become SNRIs, or serotonin norepinephrine reuptake inhibitors. It seems as though norepinephrine is the more important of the two neurotransmitters of serotonin norepinephrine for pain, and that's why the serotonin norepinephrine reuptake inhibitors like duloxetine or milnacipran are the most effective drugs in this class to treat pain. Gamma hydroxybutyrate was shown to be quite effective in fibromyalgia. It's a drug that raises GABA, but it has a lot of safety issues, so it was not approved in the US, and I don't believe it to be approved in Canada either to treat chronic pain. Low-dose naltrexone is an interesting drug. There have been several studies now suggesting low-dose naltrexone can be helpful for individuals with fibromyalgia. And we think the reason that this works in fibromyalgia is that there's actually too much release of endogenous opioids in fibromyalgia. There's high levels of endorphins and enkephalins in the spinal fluid in the brain of people with fibromyalgia. Those endogenous opioids are binding to the opioid receptors in the brain. And the more of the opioid receptors in the brain that are bound with those endogenous ligands, the endorphins and enkephalins, the less unoccupied opioid receptors there are for that opioid that you give the person to work. And this is why we think centralized pain states are inherently less responsive to opioids, is that there actually is involvement of the endogenous opioid system in these centralized pain states. A lot of controversy about cannabinoids. I actually think that cannabinoids can be effective for treating chronic pain, but this is a different lecture. CBD alone there's a lot of increasing evidence that CBD alone might be helpful for chronic pain states, and for other chronic pain states like fibromyalgia, you might need to have a little bit of THC. But one of the big problems with the medical marijuana laws or the legalization of marijuana is we haven't done a very good job of telling doctors or patients how to use cannabinoids to treat pain. We really should be starting people first on CBD alone because it has almost no side effects, and then adding a little bit of THC, but the high CBD, low THC strains of cannabis would be the most effective strains of cannabis for treating pain, whereas most of what's being given in most of the dispensaries, because the recreational users like them a lot more, are the high THC strains that are going to have a lot more side effects. But all of the drugs that work to treat fibromyalgia match up well with what we know about the neurotransmitters that are either too high or too low in fibromyalgia. All of the things that I just talked about match up nicely with neurotransmitters that are known to either be too high or too low in individuals with fibromyalgia. And I'm not going to talk a lot about this, but there are probably two different forms of centralized pain or fibromyalgia, one of which is more of a brain disorder that we call top-down. These are the individuals that start developing pain in their childhood or their teens and develop a lot of different conditions like irritable bowel and fibromyalgia and headache and painful menstrual periods, whereas other individuals might have more what was originally called central sensitization, that these individuals that have osteoarthritis and that meet criteria for fibromyalgia, that ongoing nociceptive input in the periphery might be driving the central sensitization. And so it's always important that if someone does have ongoing peripheral nociceptive input, that you treat that even if they have a condition like fibromyalgia, because it could be that the ongoing nociceptive input is driving the central sensitization. So this slide just really sort of summarizes that based on whether someone has more peripheral pain, neuropathic pain, or centralized pain, you actually can see that different classes of drugs are going to work, and that the drug and the non-drug therapies that are going to work best for peripheral or nociceptive pain are going to be the NSAIDs, the opioids, surgery or injections, whereas the drugs that are going to work best for centralized pain or nerve pain are the tricyclics, the serotonin norepinephrine reuptake inhibitors, the gabapentinoids, and the cannabinoids. But I don't want to just talk about neurobiology and talk about drugs, because non-drug therapies really need to be aggressively used to treat chronic pain. They treat different things than what we're treating with drug. A lot of what we're treating with the non-pharmacologic therapies are the downstream functional consequences of having pain for long periods of time. Even if someone didn't have stress, when they develop chronic pain, they develop high levels of stress. As they have pain longer and longer, they become less active, they start sleeping poorly, they develop obesity, they develop maladaptive illness behaviors, which are basically bad habits that people with chronic pain develop, which make their pain worse. But any of these factors down at the bottom can then feed back up into the centralization of pain. And so we really have to use drug and non-drug therapies together, pharmacologic, non-pharmacologic therapies together, to optimally treat pain. It doesn't usually work to either use only non-pharmacologic therapies or only pharmacologic therapies. The evidence base for the non-pharmacologic therapies is increasing. Education, aerobic exercise, and cognitive behavioral therapy really should be used in any individual with chronic pain, because there's a really strong evidence base. But some of the other therapies that we used to be dismissive of 20 or 30 years ago, yoga, tai chi, acupuncture, balneotherapy, chiropractic manipulation, massage therapy, are all getting a larger and larger evidence base. And so as the evidence base for surgery, injections, and opioids is decreasing, and as we're moving away from using those therapies because we know they don't work very well or they have a lot of side effects, the evidence base for non-pharmacologic therapies is really fairly dramatically increasing. This is a website that our group developed that's free, that gives people with fibromyalgia cognitive behavioral therapy, but anyone can go to this website. You don't have to have fibromyalgia, but it basically gives a lot of the underlying concepts of cognitive behavioral therapy. But we actually tested this website in a randomized controlled trial in fibromyalgia, and the website worked as well as any of the approved drugs in the US for fibromyalgia. I'm not suggesting you should use the website instead of pregabalin or duloxetine, but more so use it in addition, because the non-drug therapies really complement the drug therapies with respect to treating pain. And then a big problem in the US and Canada is we use way too many opioids. Don't have a lot of time to talk about this, but you should be aware of the fact that a slow, gradual taper of opioids rarely leads to a worsening of chronic pain. But patients don't know that, and a lot of providers don't know that. Another thing you should be aware of is you should really carefully question your patients about what symptoms they're taking that opioid for. A surprising number of chronic pain patients are taking the opioid because they think the opioid reduces their stress. They started taking the opioid because they were depressed. They are taking the opioid because it helps them sleep. None of those are good reasons for taking an opioid. There might not be any good reason for taking an opioid chronically for chronic pain. But a more careful history or interrogation of your chronic pain patient about what they're really taking that opioid for, when the opioid wears off and they take that new dose of the opioid, what is the symptom it helps first, can really help you better than work with that patient and get them to taper their opioid, because maybe you can substitute a non-drug therapy or a pharmacologic therapy for what that person is taking that opioid for. And some of the opioid-sparing drugs that you can consider using would be gabapentinoids, cannabinoids. A lot of evidence that cannabinoids are opioid-sparing drugs at both the population level and at the individual level. And if you have that patient that has chronic pain that needs to be on an opioid, it may be that the mixed opioids, tapentadol, which is a mu-opioid with norepinephrine reuptake inhibition, or buprenorphine, which is a mixed opioid antagonist and agonist, those might be the better drugs if you have to use opioids in someone with chronic pain, or especially in someone with a centralized pain state. So to summarize, I think most providers or practitioners have considered that all pain is coming from damage or inflammation out in the periphery, or is nociceptive pain. And when people have thought about central factors in pain, they've only thought of psychological factors, not the fact that different individuals have inherently different volume control or amplifier settings in their brain. And so now that we know this, that the central nervous system really sort of sets the gain or the volume control setting on pain processing, and now that we know that what these individuals, the phenotype looks like that has centralized pain, that the people will have more widespread pain accompanied by sleep problems, memory problems, fatigue, and mood problems, we now are at the point where we can move from treating pain based on the underlying disease that the person has to really looking more carefully at that chronic pain patient and trying especially to differentiate nociceptive pain from centralized pain, because the drug and the non-drug therapies that are going to work in that individual might be entirely different based on whether they're on the peripheral side of that continuum or the more central side of that continuum. So I'll stop there and take a couple questions. Thank you.
Okay, to our audience, if you have any questions, please enter them into the question and answer panel on the GoToWebinar box. One of the questions that came through is, what is Pain Detect? I don't believe this system may be available in Europe.
Yeah, so Pain Detect is a self-report measure that is freely available, but it is a measure that can help differentiate neuropathic pain for nociceptive pain. So it would be a good measure to give to someone with low back pain, where you're trying to figure out, is the pain that they're experiencing coming from a pinched nerve and more likely to respond to an injection or a surgical procedure, or is their pain in their back more centralized pain? So it's a self-report measure that was specifically designed to help differentiate neuropathic pain from nociceptive pain, whereas the fibromyalgia measure differentiates centralized pain from nociceptive pain.
Okay, another question that came through, can you decrease your sensitivity to CNS originating pain?
Yes, all those drugs that I talked about, they all work in part by sort of reducing the volume control setting, but so do a lot of non-drug therapy. Probably the single most effective way to make yourself less pain sensitive is to exercise. Exercise is a really powerful predictor of where people are in that bell-shaped curve. The more exercise they get, the less tender they are. But the other thing that is a really big determinant of where people are on that continuum is how well people are sleeping at night. Sleep and exercise are the two non-pharmacologic therapies that we use most aggressively to treat centralized pain states because a lack of sleep or a lack of exercise turns up someone's volume control and makes their pain be more centralized.
Okay, I think I have time for one more question. Can you briefly describe how some of the functional consequences of fibromyalgia, sleep problems, weight gain, maladaptive behaviors can exacerbate pain centralization? Do they provide additional pain input, potentially increasing dorsal horn amplification?
We don't really understand exactly how this is occurring. Obesity, for example, our group and others are doing a lot of work now looking at whether the adipose tissue, especially the central adiposity, that might be leading to the release of cytokines from adipose tissue that then get into the circulation and increase the widespread or central sensitization to pain. Some of the other things that were downstream, we understand a little bit better. A lack of exercise, a lack of sleep do sort of directly turn up the volume control in the central nervous system. In fact, a Canadian, Harvey Moldovsky, was the one that did those early studies in the 70s of sleep deprivation. He took healthy college students and sleep deprived them by waking them up every time they were ready to go into deep sleep, and he showed that that very soon they looked a lot like fibromyalgia patients, that sleep-deprived young individuals became more tender throughout their body, started to get achy throughout their body, developed fatigue, and were on their way to developing fibromyalgia.
Okay, I think that's all the time for questions for now. If you had a question, we will collect those and have them answered at a later time. Dr. Claw, is there anything you'd like to add following your presentation?
No.
All right. Thank you so much for your presentation then.